Evening, everybody. Thank you for taking some time out on your Wednesday to spend it here with me. My name is Andrew Chandrapal. I'm a private practitioner based in central London and in Buckinghamshire. I'm also a national and international educator. And this evening, we are going to be talking about various matricing solutions for the anterior direct restoration. So I hope the contents of this webinar gives you some insight into the variation of products out there on the market. I've tried to keep it on one hand as impartial as possible. And on the other hand, I'm going to be talking about the products that I use personally to get the results that I do. So I hope that you can see the impartiality, but also the preference in some of the results that we see today. So any questions, please feel free to put it down on the software there, and I'll do my best to answer them all at the end of the presentation. So just to let you know, I've been a general dental practitioner now. I'm in my 22nd year of doing so, and I am fortunate enough to have been a dental educator for 13 years now. I am the director of IndigoDent Education, and I go up and down the country speaking and meeting with like-minded colleagues on the basis of anterior and posterior direct restorations and tooth surface loss, as well as photography. I'm fortunate enough to also do some editorial work with journals such as Dental Update, and I'm absolutely privileged and honoured to be part of that group, as well as doing some work for the DDU, King's College London, and some of the dental trade. So my working conditions are very similar to most of yours. I work between two practices, and of which I very much am at home with general dental practice. The practice to your right is the practice that I've been at for nearly 19 years now, which enables me to see a lot of my failures as well as some of my successes. So it quite quickly validates my own work in terms of what I feel is working and the products that are helping me to achieve that success and indeed that failure. On the left of the screen is a practice that is a specialist referral center, but I operate as in a limited practice to prosthodontics, and I see referral patients on the basis of that, of whom need advanced treatment. But both clinics involve the need for various products and various entities to then serve the purpose when creating these types of restorations. So I'm going to get straight to it, and we're going to talk about anterior matrices and really the rationale. Now, I know a lot of this may seem quite obvious to the majority of you out there, but what I would like to do is kind of write a rule book in terms of when the indications of these matrices come into their own. So obviously we want to achieve predictable contact points. Now, that's the idea between that is to create an anatomical contact point where we are achieving what nature would otherwise give us. And in the anterior dentition, you would tend to find that you get a contact point that would have the variation to either be a point contact or one that's a little bit longer based upon the height of the proximal wall. We have to have an idea of primary anatomical form. And for that, good knowledge of proximal wall curvatures, or at least appreciation of the proximal wall curvature, line angle considerations are really important when we're trying to figure out the type of shape that we want the matrices to then replicate. The rationale also is when we are trying to then eliminate black triangle complications where you have, for example, attachment loss issues that have led to an unsightly black triangle, and you're trying to then infill those areas with direct resin. The use of an anatomical anterior matrix is often invaluable in terms of trying to create the contours that we need to just close up that space in the most predictable and efficient way. Also, when we're trying to conform with the anatomic shapes that we have before us, we'll realize that not every patient has the same type of curvature of those proximal walls. We have to be in a situation where we can use some form of control in the way by means of an anterior matrix system to then offer us that curvature that we need. Obviously, it then contributes to speed and efficiency with a degree of accuracy as well. And of course, it will avoid any unnecessary adherence to the adjacent tooth, especially if you are looking to place etch and bonding agents onto that surface too. So in doing so, we get a separation, but we also get the creation of something that has a proximal bulbosity, not only in an apical and a coronal position, but also in a buccal to a lingual position equally. Now, the ideal properties of an anterior matrix system would be that it is light permeable, so that the action of a light cure can then penetrate into the restorative material and cure it completely and wholly without any areas being left either soft or partially cured. We want to ensure that it's obviously easy to place, and it being easy to place, it has to be of a given thickness. And of a given thickness, it has to be then flexible or strong enough to then keep that position or shape. We need it to ideally be highly retentive. Now, that may be dependent on a number of different factors. For example, the insertion into the gingival crevice, the use of wedges, or the use of other types of blockout resins that can be cured into position to keep shape. It goes without saying, for those of us in practice, we want it to be cost effective. Some of the matrix systems on the market do come with a hefty price tag. So there is definitely not only a learning curve, but there is also a cost associated with these. And so that needs to be considered when you're pricing your restorations for patients. Ideally, it needs to be thin in cross section. So we have to ensure that the chances of then creating an open contact, especially when conducting simultaneous proximal walls, are such that the risk of that happening is relatively low. And of course, finally, we want to ensure that it is indeed non-stick to composite, especially if the surface of that matrix were to get either partially sandblasted or if it were to get indented. We want to make sure that there is a non-stick surface, ideally. Now, in terms of the requirements, what do we need? What do we need from an anatomical perspective? What do we need from a practical perspective in order to then have success with placement, retention, and subsequent results of our proximal walls? Well, these are the sort of things that perhaps you won't find in textbooks because they're very much practical tips. And the first thing I would say is probably the most important, and that is healthy soft tissues. I would tend to personally decline treatment on individuals who don't have an interest in maintaining their own oral hygiene and oral health in areas where restorations are about to be placed, especially direct restorations. And with that in mind, you need to ensure that the patient is highly motivated. And so when you apply your rubber dam, you are applying the rubber dam into areas where the soft tissue and the interdental papilla are devoid of any form of inflammation. And now, naturally, if you place some form of anterior matrix interproximally, there is a chance that you're going to engage the gingival crevice. And so doing so in an area where you have inflammation will only result into bleeding or release of GCF fluids into those areas, which is then going to contaminate your restoration, reduce your bond strength, and possibly even alter shade. So we have to make sure that our tissues are ideally as healthy as possible. We also need a reference. Now, what do I mean by that? Well, if I give you the example of there being a mid-diastema, it's often not the easiest thing to simply place a matrix system interproximally and then build a proximal wall when you have nothing on the lingual shell. So that palatal or that lingual shell needs to be there to support the matrix system that then goes into position. Now, of course, if you have a really narrow diastema, then that often isn't that easy to do. And so in these situations, you can often apply a bulk of material in one application, which takes up not only the palatal shell, but also the proximal wall at the same time. We want to have situations, ironically, where the contact point is ideally not completely tight. So in other words, we want to be able to then advance the matrix system interproximally so as to ensure that it's not indented or the form isn't changed by the existence of a really tight contact point. In these types of situations, the clinician either has one of two choices. You either have to place an instrument very carefully interproximally to then get a degree of just leverage so that you can separate the teeth for a moment whilst the matrix band is inserted, or you're having to use a diamond strip to then conduct what would otherwise be some IPR, some interproximal reduction, very carefully, trying carefully just to weaken the contact point, but not eliminate it. When I talk about relative alignment, what I mean by that is that teeth that are highly imbricated or highly malaligned may not always be the best or the easiest proximal surfaces to then ultimately achieve. And that is because application of the matrix systems interproximally can often be quite challenging. Moisture control equally can be quite challenging, and it can be also difficult to then actually get and obtain that proximal shape that you're looking for. So you do need to be careful when teeth are hugely malaligned. You'll note that many anterior matrix systems come with wedges to then help bring slight separation to the tooth or fixate the band in position. And so by doing so, it's really important that the size of those wedges is appropriate to the apical aspect that you're going to be treating, so that the band can be retained into position, obtaining very slight separation of the two teeth, but without any damage to the interproximal papillae, but also without any damage or deformation of the actual matrix band itself. Now, the ideal property is that you want your band to then return to form without any form of indentation when it's being pushed or manipulated. And most bands on the market are made from stainless steel. And so as a consequence of that, when they bend or distort, they stay in that form because of a low elastic deformation rate. And so ideally, we want to have some form of recoil or memory so that the shape of that proximal wall return back to its ideal form no matter what. Now, the other requirement often is that you do need to have some degree of apical intact tooth tissue there. And that's in order for the apical part of the matrix band to be able to engage on the apical part of the tooth, so that when you are constructing that proximal wall, you can then ensure that there is a continuation from the apical part of the tooth. In some circumstances, such as peg laterals or diminutive laterals, I'll admit, that can be very difficult to try and find. But in the majority of situations, it would be an ideal to then have an intact apical tooth proportion there. Now, if we start to then talk about not only the ideals of matrix systems on the market, but also the types. So here you're going to see one type that's very, very common, and the type that we have more than likely grown up with, if you like, at an undergraduate level or in a hospital setting perhaps. And this is called the common mylar strip. Now, the mylar strip has been used for many, many years, and obviously it's a clear cellulose strip that has no sort of curvature to it whatsoever. And so as that material is brought into proximally, the good part is that it is very thin. And so the chances of then creating a nice tight contact point are fairly high. However, because it is straight and not curved in any way, it often doesn't give us the opportunity to construct an anatomically curved proximal wall up from the apical down to the coronal. And often we can find that such mylar strip techniques will often either end in a completely vertical proximal wall, owing to then a black triangle, or an open contact, or indeed an over contoured proximal wall. Either way, it can work, but it is more challenging to do so when you compare it with other types of matrix systems that are now existing on the market. There are techniques called the mylar pull-through technique, where effectively a proximal wall is fabricated by adding a small amount of composite and a small amount of wetting or sculpting resin, and then gently pulling the mylar strip through from the facial through to the lingual, and then curing that wall that then sets into position. It's a challenging technique to consider, but it can be done with a little bit of practice and confidence. What's then come onto the market by Garrison is the Very strip. Now, the Very strip has a double curvature associated to it. So as you see in the middle slide, there is a curvature that goes from the facial through to the lingual. And if you can carefully see on the right-hand picture of the slide, there is also a curvature from the apical down to the coronal. And so by doing so, at one end, it is 5 millimeters in height, and at the other end, it is 11 millimeters in height. And you get a thickness, or rather a thinness, of 0.05. 5 millimeters, which gives it adequate thinness to then create a nice contact point that's quite nice and tight and positive. However, in the same way with your mylar strip, you might find, or it is dependent upon you pulling the Vari-strip over onto the facial to then create the curvature that's desired for your proximal wall. If you pull too far or too hard, you may find you develop an open contact. If you don't pull it sufficiently, you may find that you're doing lots of post-op reduction because it's over contoured. So whilst this is a step in the right direction, it's not perfect for every situation. However, what I would say, for very small diastemas, it can work very well indeed. And in the same way, for my lectures, this is what I sometimes take. And I have to say, I have taken this from the internet, and these aren't my slides. But if you use a mylar strip and then wedge into proximally, there is that chance that you'll create this kind of unnatural shape on your proximal wall that can easily lead to a black triangle. I admit these teeth had a degree of attachment loss anyway, but you can see my point, hopefully. By virtue of the Vari-strip, you can see how the curvature occurs in two different ways. And it's just really a matter of engaging that curvature to ensure that you don't hold the Vari-strip too tight nor too loose. And when done with a degree of experience and confidence, these can be fairly predictable. Now, if I move on to the other types of matrix systems on the market, and these are just a select few of the more common ones, and I freely admit there'll be other manufacturers on the market. Now, there are companies such as Tor VM who have then constructed novel types of matrix shapes in order to create a curvature and also a stiffness and a rigidity of the matrix band being used. So when you build up your proximal wall with composite, you are then not getting, or you're getting minimal distortion against the matrix as you push back onto the matrix and compact your composite material. The slight disadvantage with this is that it is slightly thicker as a result, and it comes in at 0.5 of a millimeter. I freely admit there may be newer variants that may have come on the market, and I do see that Tor VM offer quite a cost-effective solution equally. You do have these types of matrices from Garrison that form a curvature that fold into the buccal and the lingual aspects of the proximal wall, and they form a prefabricated curvature of which you can then pack your composite restorative into. Sometimes I have a few concerns about the light permeability of this, but equally how curved you are able to then create that proximal wall using such a stiff stent. Many of you will be aware and know and indeed use the BioClear system, which is a prefabricated cellulose matrix, which then has a number of different curvatures associated with it. It comes with a cellulose thickness of 0.4 of a millimeter, which is nice and thin. It does have a degree of rigidity to it, which is good, and largely relies on the theory of injection molding with a degree of flowable as well as packable composite to then give you a well-flowed proximal wall, which in theory can work rather well, although I do have my reservations about the combination of packable composite and flowable composite in an area that requires more cleaning than usual because of its position. And in latter points, you then have Polydenture, who have created a wonderful matrix, in my humble opinion, called the Unica matrix. Now, their matrix bands have now moved on and are now 0.3 of a millimeter thin, which is wonderful to use because the chances of then creating a nice positive point contact are then that much greater. And as I'll show you in a moment, they can work wonderfully well equally. Now, the other way we look at this, of course, is by taking a posterior sectional matrix, one with no tabs on whatsoever, and has that kind of typical kidney bean type shape, inverting it so you can seat one end into the gingival crevice, a healthy one at that, thereby making up a lovely rounded proximal wall, which ultimately fits beautifully into position. And for a single or a simple class 4 involving one proximal wall, this might be your go-to kind of methodology to then build up these proximal walls to get that anatomy that you're looking for. These types of sectional matrices do rely on a degree of adherence into the gingival crevice. they rely upon having some form of a guide, in other words, the palatal shell, as you can see here. And you can see some variances can also be Teflon coated. The Teflon ensures that it's non-stick to the composite, which is all well and good, but it does make the actual matrix a little bit thicker. So it does have its limitations. Note that the actual matrix band itself needs to be placed so that your vision of placing that proximal wall is the visual acuity is open. So there needs to be part of this that pushes through onto the lingual aspect, as you'll see in a moment. And when performed with the support of a palatal shell, you can end up to get quite a natural, thin and curvaceous proximal wall, by which you can then start to build the restorative container that is your class 4 or whatever restoration you're constructing at that point in time. So the use of sectional matrices that are indeed anatomically based, I believe is an absolute advantage in the quest to then create natural restorations. Coming back to the Polydentia Unica system, which is available from J.S. Davis, this system, I believe, is a one of a kind. And in the kit, you'll find that you get the actual bands itself, and you get a wide range of wedges that will fit into proximally to then help hold and contour the matrix to the sides of the tooth, as you're going to see shortly. You also then have sort of a grabbing tongue that can then remove the band when used, and you also then have a resin. That resin can be placed into proximally to help then hold and keep in position that that Unica matrix around the periphery of the mesial and distal aspects of the proximal walls of the tooth. And to me, I found that particularly for things like direct veneers, these can work wonderfully well. Like anything, there are limitations and there is a way to use them, and I will show you shortly. But I think these are really a game changer in terms of the use of interproximal matrix systems. And here's one in action. So here in this position, what I'm doing is performing some edge bonding, as well as reforming the proximal walls and closing the diastomers in a multiple diastomer case. And you can see how well the Unica matrix system can engage into the proximal and cervical aspects of the tooth, to the point where it can really help maintain the position of your rubber dam as well, particularly around the cervical area. Now, as you move towards the right-hand photo on this particular slide, you can see how curved and how natural it started to then fabricate the proximal walls of the tooth. And then that joins in with the existing palatal shell that I've already created. Not only that, but it also gives you a little bit of a stop on the cervical aspect, which, do bear in mind, will need to be smoothed and refined down towards the end part of your restoration, but does wonders in terms of maintaining position for your rubber dam. And I do believe that this is a unique point on this particular system. So if I go through and give you a couple of examples on cases, I think that this might be a sensible way to try and give you some ideas of the applications of these types of systems. Before I do, I'd just like to make you aware of another system that's on the market, again by Polydentia, because this is now my go-to system for simple class 4 restorations. Now, you'll have heard me talk about the use of inverted posterior sectional matrices in a situation where you're wanting to create these proximal walls for a single part of the tooth, so a one-sided class 4. One of the difficulties with that is that their cost, and also the fact that because they are steel, they tend to distort when you hit them, when you press into them too hard, or when you try and push them through contact points. The beauty of this QuickMap Flex system is that they're actually made from nickel titanium, and that not only gives them a thinness that can be unmatched at this point in time of 0.3 of a millimeter, but it also gives you this unique flexibility. Now, that will do a few things for you. That will enable the shape of that band to retain its originating shape no matter what, but it also allows you to reuse that band for multiple diastomer cases, thereby saving you costs as well. And this is now the system that I will tend to use in these single cases, in addition to the Polydentia Unica kit as well. So if I give you an example here where I'm replacing a class 4 restoration, I put some isolation in position, and you can see there's a fairly tight contact point in position here, and it's all well established, and I've got enough apical tissue to allow the band to go into position. Here, what I've done is I've selected the shades of my enamel, my dentines as well, by placing them on the contralateral tooth and ensuring that my hue, chroma, and value are all considerations to be made and concluded within the shade taking process. You can then see the Polydenture Quick Matte Flex in position. You can note that it's then taking and adopting the shape of the proximal wall that then adopts the shape of the tooth, because there's so much tooth there on the apical part. And this creates a nice emergence profile on the incisal aspect there. As you can see, it curves down. Do bear in mind that when you have situations where the shape of the proximal wall varies, you can place your finger carefully on the coronal aspect of the band and either pull it or push it gently. If you hold that as the operator, pack your composite in carefully, and then ask your assistant to then cure, you can then customize the shape of that proximal wall as you need to. That then gives me the ability to create a nice, thin, exacting proximal wall that I fully realized would need a degree of finishing to it, but it allows me to then create a bond and a union with the underlying palatal shell. I then start to then layer my dentine that I've pre-chosen into position into the restorative container cavity, as well as the bevel that I've placed, with the enamel to be placed on top. Now you can see that the placement of the enamel is relatively crude, but a little bit of finishing just to ensure my line angles are coincident. And you can see, look at the curvature that we've managed to achieve on the mesial aspect due to the use of that polydenture matrix band there. And you can see there's a degree of symmetry in the emergence profiles at the incisal edge of both centrals there, of which I couldn't have done without that type of matrix system. If I then move on to a peg lateral situation, which is a little bit more complex. Here's a situation where a young lady's been referred over, having had some orthodontic treatment completed. So the attachments or the brackets have been removed, and there is a diminutive situation with laterals, more so on the right-hand side and perhaps less so on the left-hand side, but gaps that need to be filled nonetheless. You can see that there is a Bolton discrepancy, a tooth size discrepancy between the upper centrals and the upper laterals. And so the teeth have been moved into such a position to allow me, the restorative clinician, to then start to infill composite to then make up those diastemas where necessary. Just on a slight side note, when you then look and assess these areas, you can see that the spaces that are residual are a little asymmetric because the tooth size ratios of each of these laterals is varying. And so that does make life a little bit difficult in terms of then having to then treat at the right-hand side slightly differently to that of the left. Incidentally, you can see what happens when there's careless removal of orthodontic brackets or attachments, which was a crying shame in my humble opinion. So this is the situation, and I'm assessing the occlusion to ensure that on building out interproximally on the incisal aspect, there are not going to be the introductions of any form of occlusal interference. And you must be very careful, particularly on the distal corner of an upper lateral, that you allow space for that lower canine tooth to excurse in and out in a masticatory movement. So it's important that the embrasures on the incisal aspect are not completely closed to allow the chewing functional process to continue. Now here is a cross-polarized image of the teeth, just to then affirm the shade tabs that I've actually put onto the contralateral, onto the central tooth there, to affirm the decision of the shades that I've taken. So I've placed my isolation in position. This is the IndigoDent heavy gauge latex-free rubber dam, along with some waxed floss into position so that I can engage that rubber dam as far down the cervical aspect as possible. I have then constructed my palatal shell using a wax up of sorts. So that is being used as my guide. So I then have a palatal shell on both teeth, and I must now consider to then build up the proximal wall using the most anatomical sort of reference that I can. And that's where these anterior sectional matrices really come into their own. Now, this again is the Polydenture Quick Mat Flex system, and these matrices are the same as the ones that you saw before, but are actually darker in shade, just to create a visual distinction and reduce the level of reflection that you get. And I use these commonly in these types of situations so that I can then place the inverted matrix into a healthy and clean gingival crevice, aided by the retention of my rubber dam, then giving me a nice point contact with the proximal surfaces of my centrals. So you can see here the engagements of the matrix band into the apical aspect. It's not perfect, but it gives you the ability to then finish that nicely, where you have rubber dam pulling back and retracting the interdental papillae area. You can see it beautifully. So there's the material that I've started to add onto the proximal wall. It's really important that when you start to build these areas, you make sure that your band is fully positioned so that it's not likely to move. One thing I could do here is place a wedge carefully into proximally in between the lateral and the central, or I could place some of the blockout resin that is provided within the kit, just to keep that in position and stop it from moving. If you look to the right-hand side photo of this slide, you can also see the division between the facial and the lingual. So towards the left, that's more towards the lingual. Towards the right, that's more towards the facial. It's important to realize that at this point in time, the band is placed slightly more towards the lingual. And the simple reason that is simply to open up the visual acuity, so I can see what I'm building up. I can see the amount of material I'm building up. And because there is less on the facial, there is less of a temptation to overbuild the height of the proximal wall, which is one of the main reasons that anterior restorations can appear over contoured. So we do have to make sure that the height of that proximal wall is built in conjunction with the anatomy around you. Now, at the end of that, you can see that in both cases, on both laterals, despite the different tooth size ratios, there is now a point contact in position. And I've got a thin proximal wall in place that's then going to give me that curvature that I was looking for. And just as a polite reminder, you can see that I've tried not to build the proximal walls too high, although I appreciate I'm still going to have some adjustments to do. But it's always useful when you survey and you assess your proximal walls that you look from this position to ensure that they're not overly built. And that's just a depiction of the same thing there. Now, my dentine is then placed, my enamel over the top, and here are my line angles. Now, this is where I'm starting to work at that primary anatomical form. Now, most of you hopefully will know what line angles are and how we might seek to then try and achieve as much symmetry as possible, or a degree of balanced asymmetry where necessary. But the point of this is that those anatomical matrices have engaged in creating a positive contact point with the adjacent teeth. Here is an example of one of my pre-polishers. This is the Colza Supra mini cone that's used to then pre-polish once you've used your sequence of discs to then get a nice fine finish. At this stage, I've done no polishing whatsoever, but my aim is to achieve a homogeneous surface. But once again, you can see how that proximal matrix band has then constructed a beautiful point contact between the mesial of the lateral and the distal of the central. Here is where I start to place the grid in position using an automatic pencil where the lead can snap off to create my macro morphology. And here again is the Colza Supra Twist Polisher. This is diamond impregnated to then create that gloss effect on your restoration that should give you a really consistent and predictable gloss at every point in time. So immediately post-op with the dam still in position, you can see where we are. I've got some tidying up to do, obviously. So we go from this position to that position within a single visit. Now, it's just to ensure that you understand the workflow that these anatomical sectional matrices can offer us in creating a natural, flawless result. And here's some close-ups just to show you the type of results that we can get when we're using composite, using these anatomical matrices, but also our techniques of anterior composites also then taking shape and ensuring that we can get a naturally faced outcome. You can see there's a very slight difference in the height to width ratio, but you can see all spaces are then being closed. And that's just a close-up to show the mesial proximal wall, but also some of the macro and micro anatomy that we can put into these such restorations when we're thinking from a three-dimensional perspective. Now, the next case to show you is a multiple diastema case, which was a little bit tough. I showed just a couple of slides previously, and this is in conjunction with a degree of wear as well. So we have to not only be treating the aesthetic concerns for this patient and use of an anatomical matrix system to create the natural curvatures of a new proximal wall are essential in this type of case, but also diagnose the type of occlusal disease at play here that's then contributed to the incisal edge wear that you see before you. So it's essential that you do your pre-operative assessments to ensure that you can achieve a functional diagnosis and that we fix that in the realm in the grand scheme of things. Now you will note that here what I've done is use floss ties around the teeth to then try and ligate around the cervical part, and then the rubber dam also on top. You can see the staining interproximally that will need to be removed, and thus removing the biofilm that builds up using sandblasting or aerobrading materials. Now you can see that matte look on the teeth. That's because I've sandblasted the surface of the teeth, and you can see particles also, on the rubber dam and on the putty shell there. So the putty stent is in position, just giving us an idea of the extensions that we're going to be looking at. And as I mentioned before, we want to try and use the palatal shell as a reference and a support mechanism of trying to then keep and retain the shape of the proximal wall using these such matrices. So here comes the palatal shell in position, and you'll note interproximally that the rubber dam is then doing a great job of then just pulling back the interproximal papillae tissues too. Once again, here is that polydenture unica matrix that's gone into position like a hood over the cervical and proximal areas of the tooth, showing me a really nice anatomical pathway for building up the mesial and distal aspects of the tooth, of which I'm quite happy to do simultaneously here because of the thickness of that matrix band being 0.3 of a millimeter means that the chances of me creating an open contact are very, very low indeed. So after then doing all of those restorations in the same technique, you can see the shape of those proximal walls that I've created. No doubt you can see that there are some insufficiencies. If you look, for example, to the upper left two onto the mesial aspect, you'll see that there is a deficiency, but at least you'll be able to identify that and infill that appropriately. I'm then adding some dentine, which is all shade matched. And you can see that from the side, how we're then putting that into finger-like projections and dentine mamelons. Some enamel has then been placed over the upper right central in comparison with the other remaining teeth, always remembering to look from the incisal edge to ensure the level of overbuild is kept to an absolute minimum. And then that's some enamel placed over, not perfectly so, but you can see the gross and crude additions are largely in place. And that's my immediate post-op once I've done some primary anatomical changes and a little bit of secondary material gone in position there. And that's the result then 12 months down the line, just to show how predictably some of these techniques using these sectional matrices can work quite nicely. And that was quite a tough case, and where we also needed to then rectify the occlusal disease as well. Now, I'd just like to spend a bit of a moment just showing you not a whole case, but just the application of these unica matrices, because I really do think that they're worth looking at. In these types of cases, again, you've got a degree of periodontal attachment loss. You need to redefine the proximal shape, especially in the areas of recession that we've then got. So in this type of situation, what I'm trying to do is keep free the gingival margins. And so I've placed a split dam in position. Once again, we start with that palatal shell to then try and build out to get an idea of the ideal incisal edge position. That's the crude palatal shells in place, trying to make sure that they are all separate and not indeed bonded together. And here is crudely where and how we'd place two matrices aside next to each other. Now, this carries with it a small degree of risk because you have to make sure that you've got a really nice union and a tight contact point, because all of a sudden interproximally the material is now not 0.3, it's now 0.6. So you do have to make sure that you are on top of that when you are constructing your restorations. But I thought I'd show you that for completeness. One other case, which was a very demanding aesthetic case, of which I'm actually still working on, but I wanted to show you sort of midway along this, how this can then sometimes look. This was a direct veneer that was required onto this particular tooth that had a very, very hypoplastic lesion on it that was then corrected previously. Now, it ended up that we needed to then remove the entirety of the existing composite that was in place, and thereby you can still see some of that white lesion that was there, and it's almost through and through. But you can also see sort of the destructive reduction required onto this particular tooth to get this into position, and the masking that's required from a hyperchromatic underlying tooth as well. Now, despite having rubber dam and floss ties in position, you can see that I still haven't engaged that cervical margin. And you can see it from the incisal aspect, how I'm just missing that margin, although I have got the proximal areas on show. But application of that Unica matrix just immediately improves that situation, where I can then visualize the whole aspect of the facial surface of that tooth beautifully without much of a trouble whatsoever. And that can then keep my rubber dam in position, so I've got no worries of that then creeping back down. Now, as I mentioned earlier, you can then use the colored wedges that are size appropriate interproximally to then modify this matrix band system to go into place, because the height to width ratios of many of your teeth will vary. And so the curvature has then to be customized, and that's what these wedges are there to do. So you can see how much I can then visualize of the tooth as I choose to then build this up. And I think that this, again, as I repeat myself, is just a game changer in terms of the visualization of direct veneer work. We're using this type of technique. And you could see there, I tried to then start to build up the palatal wall in an achromatic material, as we then use the proximal walls as a reference from the matrix system. So I hope I've given you some form of insight into the mainstay of the use of these types of matrix systems. And I've tried to be quite concise in my message this evening, because I know most of you don't want to be hanging around for too long. But I've tried to then sort of show you examples of these, the history and how they've evolved, the features of the ones that I tend to use, and the reasons as to why I tend to use them. It's really important to remember that you need to work with healthy, soft tissues at every single point. Support your anatomical matrix system from a palatal shell or a mock-up that's been constructed by the lab or by yourself. You must conduct some form of separation of a tight contact. That may be either by wedging interproximally or conducting a tiny bit of IPR just to weaken that contact. When you put these types of matrix systems into position, utilize the fixation methods that they have then given you. So when you find in the kits, as you saw in the polydentary example, you have a range of different wedges and even a resin that you can put into position, which is very, very handy when you don't want to distort the band using a wedge. You can use your finger to then manipulate the coronal aspect of these bands to then create the incisal emergence profile that you require. And that has to then be sort of almost foreseen when you're planning your restoration. So do use that tip. It's quite a nice way to then create as little work as is possible for the finishing process. And allow the matrix to then engage the existing proximal wall in a more apical position, so that it really hugs around the apical part of the tooth, allowing it to then continue to create this nice bulbous natural proximal wall. And you can see in the two examples here on the left of your screen, there's a diastema closure and composite veneer case, where I've then covered the facial surface, but also tried to then cover as much as I can of the interdental areas. You'll note that I haven't completely covered the interdental areas simply because I had an inverse interdental papilla in this area. And you do not want to then constrict your papillae too much, otherwise you're going to get gingival inflammation as a consequence. So do know the limits of then building out these proximal closures equally. And you'll see on the right-hand side, where we are able to then correct the midline sort of orientation using these types of systems is really second to none. And it's one that I use constantly. I like to then complete many of the lectures using this saying that I got from John Coyce originally, who I am a graduate of the Coyce Centre, and that is, do the best you can until you know better. Then, when you know better, do better. And I really think that these types of systems are ideal in a number of different applications, of which I've tried to cover a few this evening. Now, I do run a comprehensive tooth wear course that involves both the use of composite, these types of sectional matrices in both an interproximal, a facial, and a palatal build-up, along with a huge amount of theory. And I'm just providing you with a QR code through to explain more about those types of courses and other courses I hold on IndigoDent education. My next toothwear course being on the 28th and 29th of October in central London at the Darwood and Tanner Academy. So as a conclusion, really, I just want to then focus on these two products to which I tend to use the most. And it really, it's the generation of evolution, really, in terms of how these systems work. I think the flex matrices are absolutely phenomenal in terms of keeping their shape. It actually saves me quite a lot of money in terms of then utilizing one matrix band for a number of different applications on that particular case. I can, of course, use these not only in the anterior dentition, but also in the posterior dentition. And then use of the Unica system. You'll see here I've applied it in both cases, sorry, in the same case, just for variation, so you get to have a look at the difference in the two matrix systems side by side. And I think that these are definitely my preferred methods of at this point in time, because of the reasons that I've stated already. So that brings my talk to an end this evening. I'd like to thank the following companies: Polydenture, JS Davis, Colsa, and Inspiro for helping me in my evolution of my results along the way. Every time I've fed back to the companies in question, in discussion, they've been very welcoming with support over the years, and they have improved my dentistry and also improved the success rates and longevity of the results that I achieved. So I'd like to thank them all for that. You can reach me on Instagram at Dr. Floss or on IndigoDent, or you can email me with any questions or queries you have at andy@indigodent.com. It's at this point in time that I'll stop sharing, and I'll answer any questions that may be present, if at all. So please feel free to ask me any questions that you may have, and I'll be happy to answer them. Had a couple of comments saying a very nice presentation. Well, I'm very pleased about that. Thank you very much. I have a question about how direct resin can aid in adhesion to the natural tooth. Well, direct resin is something I do an awful lot of. And in these such situations, you find that direct resin can improve not only the strength of the tooth in certain circumstances when it's really broken down, but also the primary and secondary anatomy of the tooth in terms of form corrections. So there is definitely a functional and an aesthetic benefit to these types of restorations using that type of material. Just wait on any other questions. Okay, thank you very much. So if you have any questions in addition to the ones there, then please feel free to email me or contact me on Instagram, and I'll be more than happy to answer any of those questions for you as we go along during the process. But for now, thank you ever so much for your attention. I do have one or two questions, sorry. There is a question that says, what is the palatal shell made of? The palatal shell will tend to be made of an achromatic composite. Now, these achromatic composites are largely available in polychromatic composite systems. I would tend to be using ones from Colza, Venus Pearl, or the Inspiro system. And when I do that, there are achromatic shades there that will, in thin section, give me as much translucency on the incisal edge as possible. In terms of any tips to young dentists, right? Any tips to young dentists? The main thing that I would say in terms of young dentists is the same as to established dentists, and that is practice. Get some of your extracted teeth, practice on denture teeth. Try to then get some of these matrices into position, rehearse with them as best as you can. Try these on amenable patients that you have a great professional relationship with, so that they will understand that you are learning new techniques to their benefit. Take twice as long as you need to then try and master that art. Take your time, don't be in a rush, and then repeat. And if you need any help, then feel free to email me. Lower arch cases. There was a question about lower arch cases. Yes, there are a number of sort of lower arch cases that these types of matrices can be applied to, and in much the same way, the principles are very much the same. Where you are then closing diastemas, where you are trying to eliminate recessional areas or build up the incisal edges of teeth, it is very much the same, apart from the fact that isolation can sometimes be more of a challenge in these areas. But equally, inverting these types of bands and putting them into a healthy gingival crevice is often the right way to do these. You tend to find you want to be able to visualize and not make the cervical aspects of lower teeth too broad, otherwise it will make the tooth look quite rectangular, and in doing so create a ledge on the cervical margin. So I hope that then just gives you some advice. Can you please advise me what to do in a case with gingivitis? Well, quite simply, what I might suggest is ensure that that patient is highly motivated and seeing the hygienist and maintaining their own home care before you start to carry out your restorative treatment. It is essential, and I do put it down in my treatment plans, that is a prerequisite to the treatment going ahead. And I'm afraid I am quite firm with my patients on that one. So the orientation of the Unica matrix. Now, the Unica matrix does take a little bit of time to get used to, and you'll find that on the Unica matrix there is a sort of two long arms. Those two long arms have to point towards the lingual in a lingual direction, and that enables you to get this kind of hood that then hoods over the cervical and the proximal areas. Just a little bit of practice on that, and I'm sure you'll manage that. Do you etch bond once or repeat after doing the palatal shell? I don't tend to find I have to then bond once again once I've completed the palatal shell. My tooth will have been completely cleaned and the biofilm will removed and etched and bonded before applying the palatal shell. Another question, how do you get the ideal mesial and distal curvature of canines? Canines are quite bulbous. They can be quite difficult as far as that's concerned, and quite different to laterals and centrals. In these types of situations, I would be suggestive that you maybe use the QuickMat Flex matrices and then put a wedge or the blockout resin interproximally and allow yourself to shape or reshape the band when you're holding it physically in position. And by doing so, what you then tend to achieve is that bulbosity of a canine as it comes down to the coronal aspect, and then maintaining the slimmer aspect of it as you get to the cervical. I hope that helps. How do you create your matrix for the palatal shell? The matrix of the palatal shell is fabricated largely on a mock-up or a wax-up from my laboratory. I will be happy, and my nurses actually construct my palatal shells in the majority of time. But that will always be from a wax-up or a mock-up that I've done or my laboratory has done. Do you have to have a mock-up to be able to do a palatal shell? How do you do it otherwise? Well, if it's a small restoration, I might choose to be able to freehand my palatal shell. If I am freehanding it, one cheap and easy technique is to, of course, etch and bond your tooth, and you can just use the back of your finger to then create a palatal shell. What you must then do, of course, afterwards is then smooth and refine that palatal shell so that it is anatomically in continuation with the rest of the palatal anatomy that's there. Have I got another date for my toothwear course? Yes, I will be releasing dates for my 2023 cohort of delegates in due course. So please do stay on the website www.indigodent.com, and I will be releasing those forthwith. Okay, thank you very much for your questions. I will close the session at this point in time. Thank you for your attention this evening, and I hope it's been of use. And even if I've given you 1 or 2 tips, I hope that's going to be a benefit for you in practice the next day. My email and my Instagram handle is there, so I hope to hear and see you very soon. Otherwise, good evening, and thank you very much for your attention.